detection and treatment of Alzheimer's has changed for the better in recent years. Good news, no matter how old you are. Welcome to Beyond Memory Loss, the changing science of Alzheimer's disease. I'm Mary Windishar, and here's how to make the most of today's interactive session. Ask anything at any time. Just type your question into the Q&A box on the lower right side of your screen and then click Submit. You can customize your slide area by hitting the Maximize icon at the top right of the window. If the volume's too low, try adjusting the sound level on the media player. Need closed captions? Just click the CC icon to the right of the media player. If you're having technical difficulties, please click on the question mark icon, and today's slides are available in the Resources folder. Finally, please answer the questions, or the feedback questions, in the window on the bottom left of your screen. And now on to the presentation, Beyond Memory Loss, the changing science of Alzheimer's disease. Joining us today is Victor Henderson, MD, MS. Dr. Henderson is a professor of epidemiology and population health and of neurology and neurological sciences at Stanford. He studies brain behavior relations in aging and dementia. His research focuses on risk factors for cognitive aging, neurodegenerative dementia, and on interventions to help prevent and treat these disorders. He directs the NIH Stanford Alzheimer's Disease Research Center. Welcome, Doctor. Glad you're here, Dr. Henderson.
Well, thank you. Thank you for that introduction, and thank you for the invitation to be here today. So I want to talk about changes that have occurred within the field of Alzheimer's disease, the new sciences that have developed, and this has really changed the way we conceptualize Alzheimer's disease and affected the way we approach treatments and preventive strategies. So I receive research support from the NIH. I don't have other relevant conflicts of interest for this presentation. And with the changing science, I want to talk about how this has changed how we conceptualize Alzheimer's disease. There's a new definition that's been proposed that's being used in the research arena and also creeping into the clinical arena. And as well, I'll talk about how this is affecting our approaches to therapies, approaches to therapy evaluation, and some of the new therapies that have been approved by the FDA. So in talking about Alzheimer's disease, we're really talking about brain changes that are defined by the microscopic findings of plaques and tangles. So you'll hear a lot about plaques and tangles during the presentation. On the bottom right-hand part of the slide is a photomicrograph that shows two round structures. These are the plaques. These are found within the brain substance itself. The tangles are the darker staining, smaller areas that you might be able to appreciate within that photomicrograph. The tangles occur within nerve cells, not between nerve cells. So plaques and tangles are key. Key biochemical abnormalities associated with these microscopic changes are protein or protein fragment, referred to as amyloid or sometimes amyloid beta, or equivalently beta amyloid. For tangles, there's a different abnormal protein. This is tau, which has an excessive number of phosphate groups attached to it. And we'll also be talking about markers of amyloid and tau. The term biomarker just refers to a correlate or a marker or an indicator of another process that's going on. And here we have new markers for amyloid and tau that become relevant to this discussion. So I ran across this quote when I reread Gulliver's Travels a couple of years ago. This is a novel by Jonathan Swift. Most of you are familiar with it. And Gulliver, in addition to visiting the land of the small people, the Lilliputians, in addition to visiting lands of the giant, he went to other places, and one of these was a land of the Struldbrugs. These were immortal creatures, but they aged during their immortality. And what he encountered were inhabitants that have no remembrance of anything but what they learned and observed in their youth and middle age, and even that is very imperfect. And I think this is a good description of dementia, of the characteristic memory loss that is seen in Alzheimer's disease, and it's a good image to hold in mind. So dementia itself is an umbrella term. It refers to memory or cognitive loss that's severe enough to affect independence, to affect daily function. It has many causes, but Alzheimer's disease is the leading cause. There are about 7 million Americans living with Alzheimer's disease now. And the traditional way of looking at Alzheimer's disease, and it's still a very relevant way, is Alzheimer's disease is the presence of dementia with certain features, usually an insidious onset, usually with memory loss as being an early symptom, but dementia accompanied by the microscopic changes of Alzheimer's disease, the plaques and tangles that I've mentioned already, which are the underlying cause for this disorder. So standard definition would refer to these changes. The term probable Alzheimer's disease is usually used because at the time it was understood that we don't really know for sure that there are plaques and tangles in the presence of a clinical determination of dementia, but this is inferred, and definite Alzheimer's disease would then require a brain autopsy looking at the brain under the microscope. So Alzheimer's disease is named after someone. This is Alois Alzheimer. He was working in Germany during the last part of the 19th century, early part of the 20th century, and he was interested in the anatomical pathological basis of mental disease. And he said that the different mental diseases which lead to dementia, each forms a peculiarly characteristic mental impairment in such a way that in every disease the mental capacities are disturbed to a different degree and in different combinations. He supported his research by marrying a rich widow. There's a picture of Alzheimer with his family shown there in the left-hand part of the slide. The first patient that he described with the disorder now bears his name was Augusta D. She was admitted to his service in 1901. She was only 51 years of age. She died at age 55. And at the time of her death, Alzheimer at this point had moved to Munich, so her records were sent to him in Munich. He described her case at a medical conference later that year and then published further details the following year and in 1911. He described her as a woman, 51 years old, she had behavioral symptoms initially. She showed jealousy toward her husband as the first noticeable sign of the disease, but then soon a rapidly increasing loss of memory could be noticed, and that's really the most common early feature in most patients. Clinically, this patient presented such an unusual picture that the case could not be categorized under any of the known diseases, and anatomically the findings were different from all the other known causes of illnesses like this. And what were these changes? Well, he noticed at the time of autopsy that the brain was shrunken. There was atrophy. He pointed out that there was no evidence for stroke. Strokes are known to affect cognition. And he described two characteristic features. One was the plaques, and these are described as sites of deposition of a peculiar substance dispersed over the entire cortex. That block in the middle of the slide there is cortex from the brain of his first patient. I know it's hard to get oriented there, but this is roughly an inch thick, I would imagine. The top of this would be the outside of the brain. And in the upper half of this, you might be able to make out these small dark splotches. And these are the plaques that he was describing. And over in the right-hand portion of the slide are two different depictions of the plaques that Alzheimer described coming from her brain. The other change were the tangles. You can see in the bottom left some of the drawings that Alzheimer had made of the tangles that he observed. There's a new staining technique that allowed these to be observed for the first time. And he described these as a clotting of fibrils which outlived the tissue, rolled up like coils, twisted like slings as the only remnants of the cell. So Alzheimer didn't name the disorder after himself, but his mentor did this. This is Emil Kraepelin. He was revising his psychiatry handbook for students and doctors, and he then attached the name Alzheimer's disease to this disorder in 1910. This was a disorder described as dementia occurring during middle age, and for a long period of time then, this kind of dementia was identified with pre-senile or early onset disorders. Alzheimer's disease is one, and there were some others that also fit this category, but it was really uncommon. And it wasn't until later in the 20th century, not until the late 1970s, 1980s, that it became to be appreciated more fully that dementia in old age couldn't really be distinguished from the pre-senile changes that Alzheimer had described. And so now Alzheimer's disease has come to represent dementia characterized by plaques and tangles regardless of age of onset. Because Alzheimer's disease was considered so unusual, it's interesting to really track the term over time. This comes from Google. It shows word usage in, I think, popular literature. You can see the term dementia being in common usage early in the 20th century and certainly more recently at the end of the 20th century, early 21st century. But the term Alzheimer's wasn't really used until late 1970s, 1980, when this recognition occurred. This is really the first time that doctors, neurologists, scientists really started paying attention to this disorder. It was also the time that the first of the NIH Alzheimer's disease research centers was established. That was in 1984. There are now over 30 of these centers nationwide trying to find better forms of treatment, find better forms of prevention, trying to understand the pathology, the pathophysiology better, trying to come up with better ways of diagnosing the disorder. And Stanford is one of the centers that's funded by the NIH for this purpose. So let's return to amyloid and tau. Amyloid, sometimes referred to as beta amyloid or amyloid beta, it's really a fragment of a larger precursor protein. This protein is broken down. It can be broken down in several ways, and it's an abnormal breakdown that yields a fragment which can aggregate and end up forming the plaques that I've described already. So it's an abnormal protein product coming from a normal protein. In most cases, there are some genetic forms where the starting protein has an abnormality in it. Tangles are different. They're composed of tau, which has an excessive number of phosphate groups on it. Tangles are composed of something referred to as paired helical filaments. In the bottom middle part of the screen, you can see these twisted filaments formed from this hyperphosphorylated tau protein. And it's these filaments that end up constituting the neurofibrillary tangles, which are shown in the bottom right-hand portion of this slide. So here's a depiction of some of these processes. In the upper left-hand part of the slide, you can see a schematic of a nerve cell, a neuron, that has a tangle that's formed. There's a process extending up to the neuron that's coming from around an amyloid plaque where there's beta amyloid. In the middle of that, you can see distended nerve processes around this. And probably the pathology is going from the direction of the plaque toward the cell body itself. There's also some amyloid that sometimes ends up in blood vessels near the sites of these changes. And this is important when we talk about treatment because blood vessels with amyloid in it, if amyloid is removed from the brain, they can become leaky, there can be swelling, tissue into the brain, there can be bleeding that's coming from the blood vessels as well. And you can see two other pictures of one of a tangle in the upper left-hand part of the slide and a different picture of the plaques with the distended nerve processes around it in the bottom left-hand part of the slide. So while this is taking place, nerve cells are reacting, they're dying. This is a drawing of a pyramidal neuron within the brain. And early on, while the plaque is starting to develop, there's a massive loss of some of the branching that's coming from the dendrites of the nerve cell and a loss of the sites where synapses, where connections are forming. So long before we're dealing with a dead nerve cell, we're dealing with a massive loss of these branches of synapses. And so there's a loss of communication among nerve cells within the brain. And it's this loss of communication that's really responsible for the memory loss, for the cognitive loss, far before there are dead neurons within the brain. So here's a cartoon. In the cartoon, here's where I need my glasses, but
I can help you.
Anyway, it's sort of talking about walking down memory lane. Do I have that right?
Yeah, we walked to the store and bought milk.
So anyway,
oh, cute.
There's a man and his wife. They're walking along memory lane, short-term memory lane, and the man is not remembering that they just walked to the store and got milk. At the top of this is a picture of a brain, and there on the bottom left-hand portion, there's a little pink line that represents the hippocampus, the entorhinal cortex, the part of the temporal lobe that's most responsible for the formation of new memories. And so when this part of the brain is damaged, then there's difficulty learning new information, and this is a characteristic early feature of Alzheimer's disease. This is staining, looking at 3 different brains of patients who had Alzheimer's disease and died. And in the first, you can see this is staining that's identifying this abnormal tau protein. And there, the pink line is referring to the same part of the brain that I showed in the upper left-hand portion. And this is affected early on. It affects memory early on. And in the middle and in the right-hand part of the slide, you can see that this dark staining has spread. Now, the spread is not random. It follows a characteristic sequence, a characteristic pathways. And it's thought that the abnormal tau pathology spreads along nerve pathways to affect the rest of the brain. Now, Emily Dickinson wrote this poem. It's not about Alzheimer's disease, but it refers to crumbling is not an instant's act. And I think this is a good description of some of what's going on in processes like Alzheimer's disease. Dilapidation processes are organized decays. Ruin is formal, it's devil's work, it's consecutive and slow. And I think that's what's happening in Alzheimer's disease, and that's what's happening in some of the other neurodegenerative diseases that we deal with, like Parkinson's disease, like amyotrophic lateral sclerosis, and so forth. So it's thought that beta amyloid and tau these are proteins, they're not completely normal, and they can misfold. They can fold in a certain way so that when they encounter another protein, they will induce that one to misfold in the same way, and that will induce another one to misfold. And it's this progressive misfolding of proteins that seem to spread through the brain, that seems to progress, and particularly for tau protein, the spread seems to be along nerve connections. There's a spread across synapses from one nerve cell to another, and the spread involves these misfolded proteins, as I've mentioned, certainly for tau, probably in a slightly different way for amyloid beta. So it's like once the dominoes start to fall, perhaps they all start to fall. So the amyloid hypothesis of Alzheimer's disease is not new. It's been around for several decades, but it's probably what you would imagine. So the initiating event is thought to be the accumulation of this misfolded amyloid beta protein that eventually leads to the amyloid plaques that we see. It's not completely clear how this sets off the next stage of events, but it seems to be associated with a hyperphosphorylation of tau protein that ends up accumulating as neurofibrillary tangles. These tangles and the processes that are accompanying them damage nerve cells, leads to a loss of connections between other nerve cells, and eventually, and only eventually, leads to a loss of memory, leads to a loss of cognition, other intellectual abilities. And this is a process that occurs over a period of perhaps a couple of decades, maybe longer than that. So it's a slow, insidious process. In the earliest stages, it's thought to be the amyloid formation. So it makes sense that people would have thought that a good starting point for treatment for prevention might be at the amyloid stage. So we've talked about plaques in amyloid, we talked about tangles in tau. Let's talk a little bit about biomarkers. Biomarkers are really just correlates. They're just biological features that are intended to indicate something else. So an amyloid biomarker would indicate the presence of amyloid here in the brain, which would then indicate the presence of plaques, which would be a fundamental pathology of Alzheimer's disease. A tau biomarker would indicate the presence of the hyperphosphorylated tau protein, which would indicate the presence of tangles. Oops. So biomarkers for Alzheimer's disease, there are a number, but there are three that seem to be particularly important. One of these is related to brain imaging, particularly a form of imaging referred to as a PET scan, positron emission tomography. PET scanning can use different labels, and there are labels that can identify amyloid deposition within the brain, and there are labels that can identify some of the abnormal tau depositions within the brain. And so brain imaging ends up being a biomarker for the presence of amyloid, for the presence of tau, and for the pathology of Alzheimer's disease. And now, in recent years, we've been able to identify some of these markers in fluids, within the spinal fluid and within the blood, even more recently. And the science, the technology behind these is getting better and better. These are much better indicators of disease than we had even 5 years ago. So for imaging, this is an example. This is a picture of an MRI PET scanner at Stanford. So at the time a PET scan is done, there's also a structural brain image of the MRI that's sort of superimposed on top. And that blurry black and white figure in the upper right is an amyloid PET scan obtained from one of our volunteers in the Alzheimer's Disease Research Center here at Stanford. And I know it doesn't look like much, but some of the white fuzziness along the margin, that's really an indicator of tau deposition within the brain. So that would not be a normal finding. For the tau PET scan, it's been colorized in a way, an artificial way, but it makes the tau proteins, the staining, show up better. That's indicated in red here. So down there at the bottom, that is the same area that we're looking at before, the medial part of the temporal lobe, important for learning new information, for recent memory. and a different orientation view of the brain in the bottom right-hand side, the same patient showing the same location for the early amyloid deposition. Later on, this amyloid would be distributed much more widely throughout the brain, but this is one example of this particular biomarker. Spinal fluid, pretty easy to obtain, done fairly routinely in Europe. I think Americans are a little bit more afraid of this procedure, but it's fairly easy to obtain spinal fluid. And from the spinal fluid, a number of different markers can be identified. We're interested here in some of the tau protein markers and some of the markers associated with beta amyloid, but there's certainly a lot of other biomarkers that can also be measured and are relevant in some circumstances. And even more recently, the plasma biomarkers, biomarkers that can be obtained from blood, have gotten much better, can be used to identify people who seem to be at risk for having cognitive loss related to Alzheimer's disease. So we've talked about this sequence: plaques, amyloid biomarkers, tangles, tau biomarkers. But really we're using the biomarkers to infer the presence of these abnormal proteins, to infer the presence of the histological features of Alzheimer's disease. And of course we think the plaques precede the tangles. And this has led to a new definition for Alzheimer's disease. It's a definition that's being used a lot in research settings, and it's spilling over into clinical settings. So the revised criteria for a diagnosis of Alzheimer's disease is that Alzheimer's disease is defined by biology, not by clinical symptoms. So symptoms like dementia, like memory loss, aren't necessary for a diagnosis according to this definition. What is necessary is the presence of plaques and tangles, or a biomarker that seems to indicate the presence of plaques and tangles. So Alzheimer's disease, by this definition, is first evident by the appearance of beta amyloid plaques and tau tangles while people are asymptomatic. In living people, Alzheimer's disease is diagnosed by disease-specific biomarkers, and it goes on to mention the scan and some of the spinal fluid and plasma-related biomarkers that I mentioned already. So this is a new definition for Alzheimer's disease, not completely in the clinical setting yet, and I think rightfully so. But it becomes problematic, or at least thought-provoking, to think about having a terrible disease in people without any symptoms. Let me give you one indicator of that. This is a study that is looking for add information from a number of different studies where amyloid biomarkers were examined either in PET scans or in spinal fluid. It's looking at people who have dementia, who have mild cognitive impairment, but also who have no cognitive impairment at all. And that's the bottom gray part of the slide. If you look, for example, at age 70, if you move it across and look at the y-axis there, about 25% of cognitively normal 70-year-olds will have an abnormal amyloid PET scan. They will have Alzheimer's disease by this definition. Looking at spinal fluid, that number is even higher. A third of people at age 70 who are cognitively normal have Alzheimer's disease. I actually have a problem with using these terms on people who are normal, but this is where the field is at. This is where the science is at, and I think it's something important for people to think about and realize. So the definition of Alzheimer's disease, the old definition is Alzheimer's disease is dementia with certain characteristics in the presence of plaques and tangles. New definition is biomarkers that are thought to be specific for these plaques and tangles. So this concept is also relevant to some of the new therapies for Alzheimer's disease, beginning with the amyloid plaque, which may be one of the early parts of this pathological sequence that I've talked about already. It makes sense that therapies have been looking at this. In fact, it's not new to look at amyloid therapies. These approaches have been around since 2002, but it's only in the last couple of years that the FDA has approved new treatments for Alzheimer's disease, and these are the first new treatments since 2003. So this is an important illness where we really need new and better treatments. There are 3 drugs that were approved by the FDA. These are biologics that are given by infusion. I guess they're not technically drugs, but they're biologics by this nomenclature. The first was aducanumab, approved under an unusual mechanism in 2021, and then lecanemab and donanemab in 2023 and 2024. All of these reduce brain amyloid, and all these do a good job of that. So aducanumab was the first on the block. There was a really influential study, an early study that's referred to as phase 1B. This isn't one of these huge clinical trials, but it was published in the journal Nature, which is a really high-profile publication. And it looked at a 1-year treatment in a small number of people at different doses of aducanumab. And the images on the right represent amyloid PET scans. And at the higher dose, amyloid was removed from the brain. This led the manufacturers to conduct and get a red check mark of approval for this large effect. This led the manufacturer to set up 2 large phase 3 trials, about 1,800 people in each one, a 1.5-year treatment. And this drug in these trials also removed amyloid, but one of the trials didn't show any difference on the primary cognitive outcome. And in the other trial, there was a difference. It was statistically significant, but it was only 2/5 of a point on an 18-point scale, not really enough to be noticeable. And so it led to a kind of provisional approval for this medication. The medication has since been withdrawn, or at least is no longer marketed because the other drugs are perceived as being better. The next was lecanemab. It's also a monoclonal antibody. It's also given by infusion. It's given every 2 weeks. During the clinical trial, it was given for 18 months. The trial looked at people who had mild cognitive impairment short of dementia or mild dementia due to Alzheimer's disease. And the primary outcome was the same as in the aducanumab trial, and that was a change in the clinical dementia rating, sum of boxes score, an 18-point scale. And this drug did what it's supposed to do. It removed amyloid from the brain. You can see placebo at the top. You can see the treated group at the bottom, big red check mark of approval. In terms of the cognitive outcome, instead of 2/5 of a point difference at the end of 18 months, well, about 1/2 a point difference. Statistically significant, not clinically noticeable. You notice on average that everyone in the placebo group got worse, and everyone in the lecanemab group on average got worse. The differences were small, but they were statistically significant and led the FDA to give full approval for this medication. And it gets a tiny little check mark of approval there. Donanemab, similar story. It's given by infusion every 4 weeks for a 1.5 years in the clinical trials. People treated had mild cognitive impairment or mild Alzheimer's dementia. The primary outcome was a different cognitive measure, but they also looked at the same cognitive measure as a secondary outcome. Here, the difference at the end of 18 months, and the populations were a little bit different, but it was 2/3 of a point rather than 1/2 a point. Also not clinically noticeable, statistically significant. For the primary cognitive outcome, it was a different measure, a good measure. On average, people in both groups got worse. The difference was 3 points, but this is a 144-point scale. Also very small differences and probably not large enough to be noticeable to family members or patients. These drugs are relatively safe, but they do have side effects. The most common side effect is something referred to as ARIA, amyloid-related imaging abnormality. And this is due to the amyloid coming out of blood vessels, sometimes leading to leakage and edema. That's the MRI scan shown on the left-hand part of this slide. Or sometimes very tiny hemorrhages, microhemorrhages. That's the next slide over. Sometimes evidence of prior bleeding. That's the third image. And occasionally, rarely, large hemorrhages. And that's the image on the right. And there were some fatalities in these trials. They aren't very common. They can usually be identified clinically, or sometimes they're clinically silent. But they have, but it's something that clinicians have to look for carefully. These drugs are also associated with brain shrinkage. It's not clear why the shrinkage is occurring. The amount of shrinkage seems to be a little bit more than can be accounted for simply by the removal of amyloid. And the clinical significance really isn't known yet. It may not turn out to be very important, but it's something that's been observed as well. So I think it is very exciting to have new therapies for Alzheimer's disease. It's important to keep in mind that large effects on a disease-defining biomarker like amyloid do not necessarily indicate meaningful effects on cognition or daily function. And we don't know yet the long-term clinical outcomes of these new drugs. There may be more meaningful long-term benefit. There may be some long-term harm that we haven't picked up yet, or there may not be much of a difference. But I think the fact that these drugs are being used increasingly and they don't work that well is a spur to others to develop better drugs, because there's a huge market there, there's a huge need, and somebody's going to get rich, and if they can do it by making people a lot better, then I think that's the way it should be. There are a lot of drugs that have been looked at or being looked at for Alzheimer's disease. Going to the clinicaltrials.gov website, you can see that there have been over 300 large phase 3 trials that have been conducted, almost all of which have been negative or harmful. Very few of drugs have made it through this to marketing. There have been a total of 1,700 drugs looked at. Some of these are old, some of these are ongoing. This is a depiction of current drugs as of this year that are being tested, 138 drugs being assessed. So there's a lot of interest in finding more effective forms of treatment. And so I think there's a great reason for optimism. I'll point out that biomarkers are the primary outcomes in about 27% of active trials. So not necessarily whether someone gets better clinically, but whether or not one of these biomarkers is improved. And in some cases, I think that's appropriate. In other cases, I think it's really important to pay careful attention to measures of cognition and function. So what about prevention? That's a little bit different. I'll conclude with a tiny bit on prevention. Every couple of years, the medical journal Lancet does an update on factors that seem to be associated with dementia, where an intervention or change in the factors might reduce risk. So these are potentially modifiable risk factors. I'll point out that most of the evidence is observational rather than based on clinical trial experiments. And so observational evidence isn't necessarily bad evidence. It's just evidence where it's harder to be sure that there aren't some biases that might creep in. I also want to point out that a number of these potentially modifiable risk factors are related to stroke risk factors, cardiovascular disease. So factors like high LDL cholesterol, factors like hypertension, like smoking, maybe physical inactivity, like diabetes, like obesity. These all are related in one way or another to stroke risk and cardiovascular risk. And I think that's important because stroke is something we know how to prevent, or at least to some extent. We know how to lower LDL cholesterol. We know how to treat hypertension. We have better and better ways of treating diabetes, and we know not to smoke. This is a study done by an established group at Rush University. They've been following a large number of people over time, looking at brains at autopsy. That funny Venn diagram there on the left is the same data shown in the bar graph on the right, but at the time of death, for over 500 people, about 70% had pathological findings of Alzheimer's disease. And there were a number of other pathologies. A lot of these seem to be related to having stroke and vascular risk factors. Like I've said before, there are other changes, Lewy body changes related to Parkinson's disease and dementia with Lewy bodies and other changes. Alzheimer's disease by itself was found in only 8.5% of cases here. So Alzheimer's disease almost always is found in association with other forms of pathology. This diagram also comes from Rush University, looking at cognition tested annually leading up to the time of death. One unit on the x-axis represents one standard deviation. So for people that didn't have the pathologies that were being looked at, you can see that there's some terminal decline before death, but not very much. And these people are starting off fairly well. Alzheimer's disease by itself, there's a decline, but it's not dramatic. And it's only when Alzheimer's disease was combined with vascular pathology or combined with vascular and Lewy body pathology in this analysis that the decline was much more precipitous. And so even before we know how to do great things with Alzheimer's pathology, and while we're learning how to remove Lewy body pathology, we can remove some of this vascular pathology, or at least prevent it from happening. So I think a lot of our clinical efforts for the time being should continue to be focused on vascular risk. I think this is the last data slide that I have. There have been several large studies looking at intensive intervention. One came from Finland. This one was just published a few months ago from the United States. There are others going on in other parts of the world. This is a study looking at older people who are at high risk for developing dementia, don't have dementia, but they don't exercise. Their diet is poor. There are other risk factors. And the Intervention is intensive, so there's a promotion of physical activity, of mental activity, of a healthy diet, social engagement, trying to reduce cardiovascular risk. And here are the 2-year data looking at the intensive intervention group compared to the self-guided group. And you can see that there's a separation of the curves over time. Both groups on average got better. The getting better represents a practice effect of taking the test. But the group that got more better is the group that got the intensive intervention. But there's a caveat here as well. The difference here is statistically significant and small. And in terms of standard deviations, this is only 0.03 of one standard deviation difference per year. So for this 2-year trial, it's 0.06 of one standard deviation. Again, very small, and I think disappointing for an intensive intervention. It's proof of concept. It's sort of an indication that these interventions work. But I think we need to think of other approaches that are more effective more rapidly. So to conclude then, Alzheimer's disease is common. It's a really important cause of dementia, but pure Alzheimer's disease by itself is not common. It's often associated with other pathologies, and it's a vascular pathology that we know right now most about how to tackle that the most. Alzheimer's disease is being redefined, at least in research settings, as a biological phenomenon defined by biomarker correlates of amyloid and plaque. And this new definition has implications for diagnosis, for treatment, and eventually for prevention. And finally, when we think about prevention, probably we need to start earlier in life before these pathological dominoes begin to fall, or at least continue the intervention for a longer period of time than so far we've been able to do in the clinical trials that have been published. So with that, let me thank you for your attention. I'm here to answer questions you might have.
You better rest up. We've got a lot of questions here for you.
All right.
So thank you so much for your presentation. I'm going to just give a couple of announcements. We are going to move on to the Q&A portion of our event. To participate, just type your question into the Q&A window. But if we don't answer yours today, we will reach out via email afterwards. And don't forget that our guest advice is for the general population, so consult your own physician for advice that is specific to you or your family. And others have asked whether or not they can see the webcast again, and yes, you can. You can share it with a friend. All you have to do, click on the same link that got you here today. All right, we're going to dive right in. Has there been research around sleep quality and in association with dementia?
The answer is yes. There's been a lot of research with a lot of the risk factors that you would think of and some that maybe you wouldn't think of. Sleep quality declines with aging. It declines even more in Alzheimer's disease. There have been a number of studies looking at sleep disruptions, for example, in terms of cognitive decline and cognitive risk, and those associations are there. It doesn't tell you for sure what's cause and what's effect. One of the common sleep disorders that people are concerned about is obstructive sleep apnea, and there the data are a little bit mixed. We've recently published a study coming out of the population of Denmark suggesting that treated sleep apnea, the treatment probably reduces dementia risk, but it's not a huge amount. And the clinical trials that have been done looking at cognitive outcomes haven't been dramatic. But I think there's an important story in sleep that's being pursued, and we'll see what the eventual answers are. In the meantime, I feel really depressed because in my medical training I was horribly sleep deprived, and we'll see how that turns out.
Thank you. Can you discuss when is the best time or age to take a test on whether this person would develop Alzheimer's disease in the future?
So some of the biomarker tests that I referred to, you could take them anytime, but I suggest not unless there are clinical symptoms that might represent either Alzheimer's disease or sort of an early stage of that, because we don't have any FDA-approved medications for asymptomatic preclinical disease. Those studies are being done actually, and we'll know within a couple of years, whether some of these strategies, like the ones being used for Alzheimer's disease now, or some others that are being developed, actually help in prevention in that sense. But I think in the absence of symptoms, it really doesn't make sense to try to determine whether or not there might be early changes, because we don't really have good and effective treatments for that stage of the biological changes.
What about if somebody has is related to somebody who has Alzheimer's? There have been a couple questions about that. Is it hereditary?
So having a family history of Alzheimer's disease in a close relative does statistically increase one's own risk of developing the disorder. Remember, Alzheimer's disease is very common, and so having Alzheimer's disease in the family could be by chance. It could have a genetic predisposition. The strong genetic forms occur early. They're due to autosomal dominant mutation, and the proportion in the population is very small. The so-called Alzheimer gene that you hear about, this is related to a lipid transport protein called apolipoprotein E. There's one fairly common variant, maybe about 15% of the European population will have this variant, where there is an increased risk associated with it. But it's not causative in the sense that if you have this E4 variant, you're going to get Alzheimer's disease. Even if you have 2 copies, it's not necessarily the case. And if you don't have it, it's certainly not necessarily the case that you won't have it. For everyone else, there are probably lots of little genes that contribute in one way or another. But I think the best answer is if there's someone in your family, your odds are a little bit higher. But unless it's one of these rare autosomal dominant forms, it's probably not something that you need to worry about a lot.
Aerobic exercise, like running, has been shown to increase the release of brain-derived neurotropic factor, or BDNF, often called miracle grow for the brain. So, is there a recommended dose or amount of physical activity to maintain brain health?
Well, there's a recommended dose of physical activity, but let me see how I want to phrase this. If you're a mouse, if you're a rat, and you have an experimental form of Alzheimer's disease, sometimes we talk about Alzheimer's disease, then there's
what is it again? Alzheimer's?
I made that up.
Oh, you did? That's very good.
or not. There, the evidence is very good that in these animal models, exercise, it does increase BDNF, as the questioner mentioned. And it seems to delay or reduce the amount of amyloid that's being formed in these animal models. It's not clear that this translates directly to humans. We hope that it will, and certainly people who exercise more, there's an association with a lower risk of dementia. But if you're someone who goes to the gym and has a gym membership, and you're probably someone who's also eating better, it's probably watching your weight better, and there may be other reasons why this exercise dementia association is there. We don't know for sure. The recommended amount is brisk walking, 150 minutes a week, with some resistance training thrown in addition to that. There are different guidelines, different sets of studies that seem to show, maybe different figures, but I think that's sort of a good target, about 150 minutes of brisk walking a week divided up over 5 or 6 or 7 days, 7-day period.
Okay. Do you recommend taking, let's do a little bit more prevention here. Do you recommend taking specific vitamins or natural supplements for those who, and this is for those of us who are genetically predisposed? So they're throwing in another factor. But is there a vitamin or a natural supplement at all that people use to prevent Alzheimer's?
There are lots of vitamins and supplements that people take. There are lots of industries built around this. And if we knew it worked, everyone would know about it and everyone would be taking it. So I don't really recommend supplements or things like that for my patients, healthy or with dementia, apart from sort of a one-a-day, 100% RDA kind of dosage of vitamins and minerals. But beyond that, I think you're just, you're wasting money.
Okay. Is there much overlap between what is discussed today, meaning Alzheimer's, and Lewy body dementia?
They're both neurodegenerative processes, and they're both due to misfolded proteins. But the proteins are different, the processes are different. There's probably an overlap in that Lewy body changes seem to occur more than one might expect on the basis of chance alone in people that also have Alzheimer's changes. But what that connection is isn't completely clear, and I think it's better to conceptualize these as being different processes, both of which can cause dementia, the clinical symptoms of which aren't the same and differ between the two.
Is it possible that the anxiety of Alzheimer's itself can lead to dementia as people get older?
Anxiety, like depression, is one of the disorders that is strongly associated with developing dementia. But whether the cause and effect connection really isn't known for sure. So I think people who are anxious may be at a higher risk. It's not completely clear why. But I think I wouldn't worry about worrying about getting dementia.
Okay. Does the anti-amyloid therapy, which removes them from the brain, thin the blood vessels and hence possibly increase the chance of stroke?
Bleeding is a form of stroke. Stroke can either be due to a blockage of blood vessels, an ischemic stroke, or it can be due to a rupture of blood vessels or hemorrhagic stroke. And so even without these anti-amyloid therapies, some people with amyloid in blood vessels will have these hemorrhagic strokes, sometimes very serious strokes. And with the treatment, then some of this bleeding is more common. It's commonly microscopic. It's often small enough that it's not even noticed. But the general answer is yes, it does increase the stroke risk, but it's only the bleeding, the hemorrhagic form of stroke, and not the more common ischemic form of stroke.
What is normal short-term memory loss, and when should we worry? And when should our family worry? That was my part at the end, just about the family, because they
No,
worry
I always
a lot.
want to sort of give longer answers than I should. Looking at mental abilities change with aging. We don't learn languages as well as adults as children do. That's sort of an obvious one. But in terms of memory, raw memory, brute memory force, the ability to learn new strategies and approaches, 20-year-olds do better than 40-year-olds, who do better than 70-year-olds. These changes occur during life. On the other hand, as we get older, we have more experience, we have more knowledge, and this in large part compensates for maybe some of the lack of brute power that we have in terms of memorization, for example. And I think this is a normal process rather than a pathological process. And so if you think that you're not remembering quite as well as you did when you're 20, well, you're right. You're just more insightful than most people are. Not being able to remember conversations, things that happened yesterday, that's not normal. Occasionally forgetting the name of an actor of a movie, forgetting why you walked into a room. Those are pretty common and probably not worth worrying about, probably not representing something pathological, although if it gets worse, then it might. But I think in general, just thinking you have milder memory problems is not something to worry about too much. If you have a spouse or your kids say they're worried about you, then I would take that more seriously.
Okay. Can eating too much sugar lead to Alzheimer's dementia? I have heard Alzheimer's being referred to as diabetes type 3.
I think there's a strong connection between energetics in general and Alzheimer's disease.
What's energetics?
Energy, sorry.
Oh, anything gives you energy.
Yeah.
Okay.
So, and the metabolism that's associated with energy formation, cellular metabolism, for example. And there's a link between diabetes and vascular disease, a link between diabetes and vascular forms of dementia, and a link between diabetes and probably Alzheimer's disease as well. So should you skip desserts and avoid dementia? You can skip desserts and feel better about yourself. I'm not sure that that is really the best approach. But on the other hand, being sensible with the diet, avoiding simple carbohydrates, I think that is a sensible thing to be doing.
Okay. Is there any connection between kidney function and dementia?
Oh, we've studied so many different things. And the answer there is true. I don't know that there's a connection between mild kidney dysfunction and dementia. Certainly having more severe forms of kidney failure is associated with dementia. There's an association with moderate kidney disease and having increased dementia. This is something else that with colleagues we looked at in Denmark and some of the research that we've done. But I don't think the link is strong as some of the other factors that we look at and consider.
Do you have any thoughts on the cholinergic hypothesis? Do you see any cholinergic therapies beyond donepezil on the, is that right? Donepezil on the horizon beyond donepezil for both prevention and treatment of dementia?
So the cholinergic hypothesis is something that came before the amyloid hypothesis, and this was based on an understanding I think in the early 80s, of what was going on in Alzheimer's disease. So it was discovered that nerve cells that use acetylcholine as a neurotransmitter were affected early on and fairly badly by the nerve fibrillary tangles of Alzheimer's disease. These neurons occur from deep inside the brain. They project pretty widely to the cortex. They're involved in memory and attention, and it made good sense that they might be really important in Alzheimer's disease pathophysiology. And the earlier treatments that were approved for Alzheimer's treatment were based on the cholinergic hypothesis. Drugs like donepezil, and there are a couple of others that are still being used, do make people better. They're usually thought of as being symptomatic rather than modifying underlying disease. But the term disease modifying gets misused and overconceptualized in some ways. And there's some ways in which even cholinergic therapies can be considered disease modifying. Looking at drugs that are being developed that have been registered in clinicaltrials.gov, there's still a number of cholinergic therapies that are being looked at. I don't have details of what these studies are, but it's not something that's fallen completely out of favor. It just is thought to be something that's not going to make a huge dramatic difference and cure the disease.
Does amyloid removal reduce symptoms?
Amyloid removal in the lecanemab trial, the donanemab trial, the aducanumab trial, at least one of the two, did have a difference in symptoms. The difference was small, as I tried to emphasize, and I think disappointingly small. Although these were good trials, they were randomized, double-blind, there was a lot of unblinding that occurred with the bleeding, with the edema, with some of the other infusion side effects that occurred. There was an unblinding. And in a randomized trial, I wouldn't worry about this too much, except the differences are small. And you worry, was the unblinding, did this contribute in some way to the difference that we're seeing? But I guess the answer is it probably did improve symptoms. It didn't improve it very much. It may be that the timing wasn't right. It may be that the duration of treatment wasn't right. But symptoms were improved, but only a little bit.
Okay. All right, this question is regarding my 82-year-old mother, who's definitely losing her short-term memory. So she asked the PCP to refer her to a neurologist, but the PCP says they don't see any signs of memory loss. And this is because her mother practices drawing an analog clock, memorizes standard answers to questions such as today's date, president, vice president's name. What would you suggest that I do to get a referral for her to be screened by an expert, in other words, a neurologist, for early dementia?
Well, one comment is if your mother is able to practice these things, then she has her wits about her to that extent. But that's not to suggest that your observations aren't valid, and there may really be important memory loss going on that a busy practitioner, primary care practitioner, may not appreciate or may just not notice the subtle changes. If you're in a situation where you can make an appointment yourself or for your mother without going through a referral process, then do that. Otherwise, I think maybe being a little bit more insistent to the extent you can do that nicely might be the way to go. But in a lot of settings, you don't have to have a referral to see a neurologist. And you might contact, if there's a university near you, for example, a medical school university, to see if they would accept self-referrals.
Okay.
Most will.
Recently, we've been hearing more about the long-term negative effects of inflammation on the body. Has there been specific research into the association of inflammation with dementia?
There has been a lot of research on inflammation. This has been going on for decades. Even at the very start of my career, it was one of the important hypotheses as to some of the processes going on. There have been a lot of anti-inflammatory therapies tried for Alzheimer's disease treatment. But inflammation is a really complex process. There's so many different factors involved. And even though it's been looked at for a long time, even though it's been looked at in terms of treatments, I think there's still a lot of unanswered questions. I think inflammation still plays an important role in some of the pathophysiology that we're seeing. And so a simple answer is yes, I think it's important, even though it's not something new that's being looked at.
Okay. This is taking on. What should be part of an annual checkup to detect and track dementia risk?
It's a little bit controversial. I think Some people advocate having memory kinds of testing done within the office. I don't think that's a bad idea, but these simple tests, our president took one of these tests several years ago, for example. They can be misinterpreted. There can be artificially low scores that don't indicate dementia. There can be people who score pretty well in these simple screening tests but actually have a fair amount of cognitive impairment. But that might be something that could be done. There are some people who advocate that. I don't have strong feelings one way or the other myself, but there's certainly people that do feel that this should be part of an annual screening examination after a certain age.
You know, you mentioned some things that we can do to prevent it, things like socializing with other people and stuff. This says here, what are the types of cognitive activities known to prevent or even stabilize dementia or Alzheimer?
So we're dealing again with sort of association. So people who stay mentally active seem to have a lower association of developing dementia. I think in terms of the type of cognitive activity, we don't have good evidence that one type is better than another. So there are computerized programs that do this, and for people who like those kinds of programs, I think that's fine. But for people who like reading books, going to book clubs, learning to play a musical instrument, playing cards, doing interactive things with grandkids, I think there are a lot of different kinds of activities. There's no good evidence that one is a lot better than others. I certainly don't recommend sitting around watching Wheel of Fortune all day. But if you're staying cognitively active, mentally engaged, then the particular type of activity probably is not the crucial factor.
Okay. You know, this is implied in all of these questions here about how to prevent it. What do you do to prevent Alzheimer's? Because you know all about it.
Oh, good question. And I probably don't do things a lot differently than others do. I watch my diet. I try to exercise.
Do you worry about it ever?
I worry about it to the extent that I think everyone needs to worry about it.
And what is that extent?
I think by age 90, age 100, almost everyone will have some of the pathological changes of Alzheimer's disease. All of us will have some of the changes of vascular disease. A lot of us will have these Lewy body changes. And so I think it's hard to make it to 100 without having important mental and physical abnormalities, although a few people do. And those few people are valuable to study. There are lessons there. There are genetic lessons to be learned. There are exposures and environmental lessons to be learned. And so, but in general, I do the same sensible things I think most people do.
Okay. What is the best resource for learning about trials and new treatments and how to join them?
So trials in general, you can go to a website called clinicaltrials.gov. All clinical trials are required to register there. It's not hard to type in keywords like Alzheimer's disease and find trials. For a layperson, it's then a little bit harder to dig down and see exactly what's going on, but there is some contact information. The Alzheimer's Association is a national organization, has a lot of regional offices, and they have a trial registry. There are other trial registries as well, but the Alzheimer's Association would be a good source of information. Most medical schools have people doing some Alzheimer's disease studies, Alzheimer's disease trials. Different universities, different places will have different trials, but that's another place to go and find out what's going on.
Clinicaltrials.gov, right?
Exactly.
For that one. Okay, great. And how does one get a test for early symptoms of Alzheimer's or dementias? Where do you start?
Start with your primary care physician.
And that was a fast answer. What are your thoughts on the Welcome Leap Care program on Alzheimer's risk through endocrinology?
Say that again.
What are your thoughts on the Welcome Leap Care program on Alzheimer's risk through endocrinology?
I'm not sure I know what that is, although it might be the program that's looking at hormone therapy and estrogens.
So endocrinology could be that?
It could be that.
Okay.
And
what do you think?
I don't know. At one point in my career, I did a lot of research related to hormone therapy, particularly estrogen and dementia risk and in relation to cognition. I think it's still an area that is being looked at. I know that the Wellcome Foundation is funding some research in this area even now. And just this week, the FDA suggested that the black box warning around estrogen, around hormone therapy, be removed because hormones have sort of a broader spectrum of effects, some of which are beneficial than was previously recognized. In terms of dementia, if this is what the question is referring to, I think we still don't know whether hormones like estrogen increase or reduce the risk of dementia. The Women's Health Initiative suggested an increased risk in dementia, but this was a study done in older women, and even though the underlying parent study was massive, the actual study looking at dementia outcomes is fairly small. Observational studies, and we were involved in a lot of these, suggested protective associations. And so I think the best suggestion is hormone therapy shouldn't be used to prevent dementia. We don't have enough evidence to say that it does. But probably one shouldn't worry too much about using hormone therapy for a woman in her 50s, in her 60s, up until age 70. After that, then I think other health effects become large enough that there's net harm rather than net benefit.
There are so many other questions. I'm so sorry we can't get to the rest of these, but we will answer them via email after today's event. Can you give us your closing comments, Dr. Henderson? What should we walk away knowing?
I think you should walk away knowing that Alzheimer's disease is really common. You probably knew that already. But based on this new definition, looking at biomarkers, that the biochemical changes of Alzheimer's disease are more common than we appreciated. They occur at an earlier age than we appreciated. And I'm hoping that this kind of science, this knowledge of biology, is going to spur new interventions that are more effective than what we have now. We need more research. I think this is not the time to slow down or let up. But we aren't at the stage where we need to be. And I thank everyone for the support in trying to come up with better forms of prevention and cure.
Thank you so much, Dr. Henderson. Now, through your company's partnership with Stanford Medicine, you get these webcasts and access to our full library. And once again, if you missed any of today's webcast or you'd like to view it again, it will be available on demand using the same link that you used today. Thank you for joining us this year, and we will see you in January for our next webcast.
Thank you.
I'm Mary Windishar, and on behalf of Dr. Henderson and our team here at Stanford, happy holidays, including Thanksgiving, and thank you for joining us. And we're sure glad you were here today. Thank you.
Thanks so much.
You're welcome.